So welcome to this presentation about hypertrophic cardiomyopathy in children. First, for the definition, we have the non-obstructive HCM, which means hypertrophic cardiomyopathy without obstruction of the left ventricular outflow tract. The other one, which is the hypertrophic obstructive cardiomyopathy, HCM with left ventricular outflow tract obstruction that is dynamic. HCM is the second most common cardiomyopathy in pediatric population. Two types are distinguished: obstructive type and hypertrophic obstructive cardiomyopathy. That's 70% of the cases, while the non-obstructive type is 30% of the cases. Alongside with myocarditis, HCM is one of the most frequent causes of sudden cardiac death in young patients, especially in young athletes. For the etiology, HCM is a genetic condition characterized by otherwise unexplained left ventricular hypertrophy. Most common hereditary heart disease, it is inherited in an autosomal dominant way with varying penetrance. Most commonly caused by mutations of the sarcomeric protein genes, for instance myosin heavy chain, myosin binding protein C, and disorganization of myocyte architecture characterized by myofibril disarrays and fibrosis. Other conditions that are associated with left ventricular hypertrophy include the following: chronic hypertension, which is the most common cause of hypertrophic cardiomyopathy, but more for the adult population; aortic stenosis, Friedreich ataxia, Fabry disease, and Noonan syndrome; also amyloidosis. The pathogenesis of the hypertrophic cardiomyopathy is characterized by hypertrophy of the left ventricle. Most commonly occurs with asymmetrical septal involvement, which leads to diastolic dysfunction, so impaired left ventricular relaxation and filling, then reduced systolic output volume, which further leads to reduced peripheral and myocardial perfusion, and then cardiac arrhythmia and or heart failure, and this increased the risk of sudden cardiac death. The clinical features of this disease: the symptoms worsen with exercise, dehydration, and use of certain drugs, for instance digoxin, ACE or ARBs, diuretics, and hydrosalicin. It's frequently asymptomatic, especially for the non-obstructive type, which accounts for 30% of the cases. Dyspnea on exertion, angina pectoris, dizziness, lightheadedness, and syncope. Syncope is a very important symptom of this disease. Palpitations, cardiac arrhythmias, and sudden cardiac death, particularly during or after intense physical activities. The physical examination will reveal a systolic ejection murmur, which is crescendo decrescendo. It increases with valsalva maneuver standing or with inotropic drugs, for instance digitalis, and decreases with hand grip, squatting, or passive leg elevation. Drugs that decrease contractility, for instance beta blockers, also decrease the murmur. A possible holosystolic murmur from mitral regurgitation can be heard, and a sustained apex beat, or an S4 gallop or a paradoxical split of the S2 upon auscultation. The diagnosis. Here, echocardiography is the best initial and confirmatory test of the disease. Other investigations like ECG, chest X-ray, or cardiac MRI, exercise testing, and screening for coronary artery disease or genetic disease can be done on a case-by-case basis. The indication for the transthoracic echocardiography with Doppler, which is the golden way of diagnosing this, is initial assessment of patient with suspected hypertrophic cardiomyopathy. Repeat testing in patient with a new cardiovascular event or change in clinical status. Findings with HCM is wall thickness, which is a symmetrical thickened left ventricular wall more than 15 millimeters, typically involving the septum. Left ventricular wall, lateral ventricular wall thickness of more than 30 millimeters is associated with a high risk of sudden death. Outflow tract abnormalities reveals systolic anterior motion of the mitral valve, mitral regurgitation, or LVOT pressure gradient increased via Doppler echocardiography. Findings which are more specific to HOCM is asymmetrical thickened intraventricular septum or dynamic LVOT obstruction due to the contact between the septum and mitral valve during systole. The treatment. First of all, the general lifestyle changes, so avoidance of dehydration and maintaining a healthy body weight. Also, avoidance of strenuous exercise and situations that will likely cause vasodilation. In symptomatic patient, the goal of treatment is to alleviate the symptoms of HCM by slowing the heart rate. Initial therapy for all symptomatic patients with obstructive or non-obstructive HCM. The first line is beta blockers. The second line treatment is verapamil, so non-dehydropyridine calcium channel blocker. And there are also pharmacotherapy to avoid, such as digoxin and high-dose diuretics. For the surgical invasive therapy, it's usually the ones which are refractory to medical therapy. So there is a septal reduction therapy for severe symptoms, where you can do a surgical septal myomectomy called the Morrow's procedure, or transcoronary ablation of septal hypertrophy when surgery is considered too high risk or is contraindicated. Implementation of a dual chamber pacemaker is to consider for the patient who are poor candidates for the septal reduction therapy, and eventually heart transplant if none of the other therapies will succeed. Here you see a ECG of a 17-year-old girl with hypertrophic obstructive cardiomyopathy with marked septal hypertrophy. Note the prominent Q waves with the absent R waves in lead V5 and V6. Here we see an echocardiography from a parasternal short axis view of a 14-year-old boy with hypertrophic cardiomyopathy. Marked hypertrophy of the intraventricular septum as well as the posterior wall of the ventricle is present. The left ventricle cavity is small. The intraventricular septum is approximately 39 millimeters and the left ventricle posterior wall is 26 millimeters thick. The thickness of both structures does not exceed 10 millimeters in a normal person. Thank you very much for listening.